Hi, everyone. Thanks for coming. I wanted to really thank Erin Kaleba for coming today. Erin is the Director of the Research Data Warehouse and Data Director in the Data Office for Clinical and Translational Research. The Research Data Warehouse and the Data Office represent critical facilitators to advancing Michigan Medicine's innovative and translational research by enabling secure access to data from multiple sources. Erin thoroughly enjoys partnering directly with investigators and academic departments to translate research needs into technical solutions with an experienced team of database programmers. And today, Erin will talk to us about some of the data resources that are here at the University of Michigan for research purposes. Thank you.
So just real quick before I get started, let me know what type of research you do. So Gary, I know about PEACH and the equities research. What's your focus?
Opioid policy.
Yeah, that's where we saw each other a couple months ago. Yeah. And I remember I just met you. Do you do pulmonary?
Yes.
Yes.
So pediatric asthma disparities, and we met in the telehealth
Telehealth
networking.
Okay, great. How about you? What's your?
I'm a postdoc and I've been working with Sarah Reeves with the Sickle Cell Data Collection Program.
Okay,
And now I'm also working with Gary and Susan, Gary Freed and Susan Wolford with the PEACH Project.
Oh, good. Okay, great.
I'm also a postdoc and I work with Cow. And I also work with Sarah Reeves on sickle cell disease. I mainly evaluate the impacts of health policies.
Oh, nice. Okay, great. Thank you. And how are you?
Oh, I'm a research assistant. I work with Dr. Reeves on the same project. I could read as a team here. Something like that. So you have also Dr. Reeves.
Okay, great. Anyone not with Dr. Reeves?
Yeah.
What's your area?
Sabine Modium, pediatric nephrologist, and I run the pediatric nephrology research program, formerly run by Debbie's.
Oh, yes, I know that program well. You still have the same programmers? Yeah, Richard, yes.
Joe Coney, Peach Critical Care,
Nice.
do clinical health services research and ARDS and ECMO.
Oh, nice, great, okay.
Ryan Barbaro, same.
He works with Jen.
Years ago, about the, not a spin-off company, but like, it was like a project related to early collection of that.
I think the Wilds was now.
Yes.
That's right,
Oh my
yeah.
gosh, good to see you again.
Yeah.
And then Dr. Adler, I recognize you.
Hi, sorry, I'm on Zoom, but yes, I'm here too, and I do research in inflammatory bowel disease, Crohn's disease, ulcerative colitis, as well as collaborate with other people in CHEAR.
Okay, thank you. And Jennifer?
She's
Hello, I'm Jennifer. I work on Dr. Freed's team.
Great, good to meet you. Kevin?
Hi, I work with Joe Coney. I've mostly been working in the FIS database recently, but also with interest in ARDS and PEDS critical care.
Nice, thank you. Krista?
Hi, I work with Dr. Reeves on sickle cell stuff.
Excellent. Thank you, Julie.
I work with Dr. Freed, project manager.
Good to meet you. Jenny Lee.
Hi, I'm a PhD candidate from the Department of Learning Health Sciences, but I work with Dr. Reeves as well.
And Dan.
Hello, I'm Dan Stanish. I'm a BI analyst. I work with Dr. Lee.
Thanks, you guys. It just helps in case, I can tailor my comments to the types of data you need or the research you do. So everyone does some aspect of health services research. And all peds or?
Yes.
Like, so even yours is opioids and ped? No.
No, I do. Lifespan. So
Lifespan.
Lifespan as well.
Okay, right, okay.
The rest of us just care about children.
That's true.
Yeah. 100%. These other people are just losers.
Oh, I love it. Okay, so let me see if this is still, no, it's not sharing. 1 second. So I'll talk about some of the services you guys know already, but there may be enhancements to those or new data or new functions. If you've already used them, hopefully there's something that's there now that wasn't when you first used it. And then I'd love to hear where we should go next. We're at this point where we where we've gotten all the low hanging fruit, and now I kind of need you guys to say, we need to go deeper in this. We need to partner with Sparrow now that, you know, they're an affiliate site. So I would love to hear, so my faculty lead is Sachin Pitterpaul, and we built these resources 8 years ago now, and they're pretty well used. We just are always like, is there something better out there, or do we just continue to invest in these? So, yeah, so today I'll just talk about some new data we've acquired. And same data, but from new places, and then new services that we're offering. So I liked, Kyle said, can you talk about evolving needs and evolving resources? I think it's funny that this one starts at spreadsheets, because we started like with paper charts. Like spreadsheets were fancy when I got started in quality and research. And I don't know where we are on here. I'd love you guys to say where we are. Maybe data marts, I don't know yet if we're to this big data ecosystem. Whenever I go and try and recruit some interns, like from computer science and engineering, they're like, I want to do big data. Are you big data? I'm like, we're a lot of data. Big. But I don't think we're to the fully walking.
I was gonna say somewhere in between there.
Somewhere between the last two. But the Office of Research in the medical school recognized that there were these needs all along the way of a research data life cycle, and they were painful. If you're from a big resource-rich department like anesthesia, you might not think any of these are troublesome. How you do cohort feasibility at the beginning, how you do storage and data sharing. Now the NIH says you have to share, Michigan says for 7 years, you have to store your data for 7 years. NIH says 3 years, but how do you share it? And how do you make sure there's no identifiers, and who can use it? And do they need a DUA? And how do you not get scooped on all that you put together for years? That's how you make tenure. I mean, so they said to Sachin Pitterpaul, like, you've done this for anesthesia, because anesthesia only got on the Epic product like a half hour ago. I mean, they would have been forever on Centricity. So they made this mini data mart for anesthesia, and they said, do it for the entire health system. So 20 years worth of data in some form of electronic record, and to do all these different types of things. So this was one I heard at Peach. It wasn't just teens though, Gary. It was, are we testing STIs in young people with disabilities at the same rates? That's just something you should be able to do in like 2 minutes. Say, is there a difference in the testing rates, and then in the infection rates, of course. Would you believe I put sickle cell on here, Sarah, as a, but lots of different things we could look at with 20 years worth of retrospective data. It's only one health system, but you could still begin to say, are there some patterns? Should we look into doing something prospective? We've done a lot with trying to increase rates of recruitment into industry funded trials. So you can get an email from our tools every morning, every week that says, of your eligible population, here's who's coming in to your clinic, here's who's going to be at, radiology next week, and you can put someone right there. And then we're increasing the number of outside data sources, so environmental data, pairing that with, trips to the ED for kids with asthma, things like that. And then participation in multi-center registries. As you guys know, NIH and others are less interested in funding single centers now. They really say, form a network, get your ends larger, get some more representation of different patient populations. So we're not the IRB and we're not compliance, but we put all of the requests through the lens of those two regulatory bodies, so that when you get data from us, we've read your IRB, we've looked at where you're storing it, and then we can help you share it in a way that ensures patients have consented to send their tissue to industry or their data to industry, that. So that's, we're kind of the effector arm of those two regulatory bodies. And so we've tried for years to become the front door or the go-to place. I don't know if we're successful, but maybe because we've changed our name 3 times, it's hard to find the door when it, but this is the goal, is that if you have a question about anything data related, you could come to us and we would help point you in the right direction. So right now, starting local, we've really spent a couple of years harnessing that electronic health record data. Who's used Data Direct? You guys almost all have, oh, and I can't see. Oh, there they are. So within Data Direct, you can then see who has got GWAS data available. There's 100,000 patients at Michigan Medicine. PEDS is very small. It started with a project called Big Bird, but it started in nephrology, as you know. And actually, we learned a lot about consenting. If you ask someone to just contribute their DNA and lots of other data about them, when they aren't there for a specific health concern, it's a tougher sell, especially among kids, than if you have a child with a severe illness. The family is much more willing to say, please study this, please don't let anyone else go through what our family is going through. And so I thought it was really smart to start with like kids with kidney disease and, you know, parents who, you know, were very committed to helping find something. Do you know what the N is of kids with GWAS data there in the hundreds? Yeah.
Yeah, probably in the hundreds.
Yeah.
Matt restarted it at Boston, so he's got larger
That's-
ends now.
Okay, that's what I thought. What was his name? Samson?
Samson.
Yeah. Geolocation data is great. Gary and others in Peach are helping us really explore that. Wearables data is kind of out of control, and I would love your thoughts on how it would be helpful to view this. And then claims data. I've learned a lot from Sarah and from IHPI about how, you know, CMS and the Blue Cross wants these data used, how they don't. You know, how we can expose them more widely. So there's two pathways here. When I talk to other health systems, Duke, others, they almost have no self-serve access. So we're very unique in that Michigan, which is a fairly conservative place from a data standpoint. Dr. Runge is really conservative about data, but the ability to do self-serve access is pretty incredible. So Data Direct, we have a lot of people going right against the research data warehouse backend if they can do SQL polls. Emerse, and then Encore, I don't know if you've ever used it, but if you have GWAS data, you can upload it and do association studies against reference sets like the what's the big one in Britain? I can't remember it, but other reference sets, a lot of them are European based. And then custom data extracts is what we do a ton of, several hundred. Dr. Adler and others have had us pull data for them, but when you get a custom data pull from us, it's a little cleaner than you get out of the self-serve. It's a little more organized. It does have a recharge rate of 65 an hour, but it's a lot less time cleaning the data. It's just not as, sometimes there's a nice hybrid method where someone will say, I found my population in Data Direct. Here's the 400 medical record numbers, but to get all the information on them kind of organized, if you guys could do just that. So you guys all know Data Direct, I think, but let me tell you about some new data in it. This is what I was just mentioning. Before, people would kind of adjust for socioeconomic status using Medicaid. Yes, no Medicaid, and that's a pretty blunt way to say this person is disadvantaged or more advantaged. So geolocation has some really granular data that's based on the census block ID. So we took latitude and longitude of everyone's street address, including a history of past street addresses, linked those to a geocode, which was then the census ID. And so there's more than 100, you know, social and economic data elements, not about that patient, but about the block on which they live. And so percentage of households on this block where it's immigrant, you know, status, where it's female led, where it's less than 30K income a year. It's an amazing way to risk adjust a little. Gary, do you have any experience with some of the researchers in Peach using this?
So right now, the question that we have actually is whether or not what's the strength of using the indices, like these are indices. It's not like, from my understanding right now, we're not able to, through the Data Direct, we're not able to break out the different components of the index, but we are looking with different indices about how we're able to like break out, like say if we just want household income,
Yes.
not the index, how do we pull out just that piece of it? But the index in and of itself is a huge step forward from people who were using zip code and, you know, other and you can look in the literature and people are still using these exceedingly blunt instruments that are irrelevant. So this is a huge step forward. to
So
use
I'll
this.
show you, you can get down to each individual component that goes into the
Index.
index. Yeah, if there's time, I'll do it. You need IRB for that level.
Sure.
But your researchers all.
We do all, yeah.
IRB. So yeah.
I have a lot of questions about the geolocation.
Great, okay.
Can you talk a little bit about two things, how that the historical look back works, and like, is it date stamped, you know,
Yeah.
by what? You know, when we, you know, a lot of our claims data collection lags a couple of years.
Yes.
And so when we think about, you know, even linking or tying on address, you know, if address is the point in time that we see in data direct, but we're looking at 2018.
Mm-hmm.
Are you saying that there's ways to get at that historical address data in here?
Right, so the way it would come out in data direct is that you would have, let's say I'm looking at household income. And that's one view, and there's several data elements, so several columns about household income. Each patient would have multiple rows. Each one of those would be a different address in the past with
Okay.
a time date stamp.
Like the date it was changed?
The date their address changed, and
Okay.
then the geolocation information associated with that date. Now,
Okay.
census data is every 10 years, but there are other, you guys, the amazing thing is this all comes out of our institution. Like ISR does so much of this. And if you need help interpreting what you can and can't say about geolocation data, Philippa Clark is like the resident expert, and she's right here at Michigan. She's just so happy people are using this. But so, right, so it would be for each street address, what the data were associated with that at that time and date.
Okay.
So you could be like, well, I'm looking at a time period, I've got payment data from, you know, 2010. Where did they live at that point and what were those? Sure, so I could show you that, yeah.
Sorry, but following up on this, say they didn't enter the University of Michigan system until
Oh.
2015, can you get it where they lived in 2010?
Not as well. Patients don't tend to, well, we don't ask them, where'd you live?
Right, so it's just the information that
Since they-
patients give in demographic and
That's exactly
interactions
right.
with university.
That's a great point, yeah. And you know who's the worst? Students. Because every year I lived at the university, I had a different address.
And then your SES data elements, where are those? Are those coming all from ISR? Are they all
They're-
census? Are they?
Yeah, they're a combination of different national surveys, the
Okay.
census. But some are about proximity to parks, proximity to fresh food. Those are all done on like a national survey, most of which are run out of ISR, but I don't think all. But it's all done under this umbrella called NANDA, which is the neighborhood something.
Oh, okay,
Yeah.
got it. Thank you.
And I think that looks like Kevin Domkowski has a question, so does Jeremiah. So Kevin, can you go first?
But actually, I took my hand down because I channeled my question through Sarah Reeves. She
So
asked,
Jeremy,
As did I. I was wondering about historical address data. Thank you.
all right, great.
Can I channel stuff through Sarah? So the other one that is directly patient reported is Partners in Primary Care, and I don't know if you've used those data. We ask a lot of surveys at Michigan Medicine, not all of them make it into my chart, but this one does. And I get asked this every time I go to the doctor. Did you not pick up your meds because you were worried? Did you not pay rent? Are you worried about food for your family? Things like that.
I have another question on that. I'm
Yeah,
sorry.
please.
If that is recorded on paper, how does that or is it in any clinics and does it get to? the
I
children
think
then?
that is the, you know, like each clinic has a different process.
I'm pretty sure I
For
do paper.
pediatric primary care, by and large, it is entered in, because we're searching on that right now for one
Are
of our
you?
projects.
It's like
And they're
2
pretty
years
good
ago, West
Yeah.
Ann Arbor was still paper.
I understand.
Okay,
I'm just
but now
saying
it's back.
now-
Months ago, West Ann Arbor. Was it? I wasn't sure when it.
Now, on the specialty clinics,
Sure.
can't speak to that, because many of them weren't even doing this until, and some still may not be even doing this now, but this is just in primary care. You may fill it out in paper, but then it gets entered by the MA.
By the MA. Like theoretically or actually?
I can just tell you in my personal experience, it actually happens
Okay.
at Canton. I cannot tell you if it theoretically happens at every clinic.
Thank you.
I don't know if you guys have used these, if these are helpful, maybe we could come up with some new ones. Computable phenotypes are great efficiency. That rather than creating your population from ICD-10 codes or definitions of surgeries or whatever, you just say, I'm gonna pre-bake that definition. I'm gonna come in and grab that same population each time, and I'm gonna then just get to work on. Primary care patients was a big one, surgical patients. If there's any, you know, IBD patients or ARDS patients, that would be helpful. If you're coming in and building that again and again, if you're not, you probably don't need it, but there's pretty good national definitions of things. The worst is heart failure, but that one we change all the time because someone's like, I just saw a new definition, so.
We're
yeah.
building many, we're trying to build many for kidney disease. in
Yeah.
Various like either rare diseases or not. Partially back to the point you made earlier about industry sponsored trials and things like that, and mostly in the kind of development of planning for trials and planning for kind of those types of things. But then also kind of for the research as well. So at some point, most of them are multi-center right now, but
Okay.
it'd be good to know at some point if after all the multi-center stuff comes back, that they actually
Yeah.
work as well. as most of them
Are they
back.
pretty well-defined population?
Depends on who you ask. We're still working that part out.
Okay, yeah, I'd love to hear more about that.
Yeah, we can talk about it.
Okay. And then recruitment, I don't know if you've used this or if it'd be helpful, but you can define your eligibility criteria. How frequently you want to know when they're coming in, so it'll say, here's patients coming in the next week or month for a visit here, if you want to recruit them. A couple example, I think in terms of examples, so I threw these in here, but the one is just cohort mode without IRB. A pediatric plastic surgeon wanted to know, were there differences between two types of cleft palate repair surgery? So we were just able to like look at the two different types of surgeries and then start to plan. Yeah, Gary.
Could you go back one slide,
Yeah,
please?
please.
Sorry, I was just thinking, so to do this, I find fascinating. I didn't know we did this. So like if someone would create a list of diagnoses, age range, blah, blah, blah. We could then know when and where any of those kids are coming in.
Yes.
Thank you. I had no idea. That's really great.
I can demo it too.
I'll be back in touch, but thank you. This is
Perfect.
wonderful.
Okay, perfect.
That was really great.
That's the thing, and if you don't need these features or functions, you kind of like, but if you need them, then you didn't know we had them, you know, that's. So anyway, this was very possible. This is Rocky Elma. So she was able to see there were enough cases of both types of surgery. She finally got IRB, and then she was able to look at the financial burden on the families based on one of two types of surgery. How much speech therapy, how much school miss, things like this. This is a fascinating study. Chris Frank from Family Medicine. I don't know if you guys have heard about this. Do you know this one? Were you part of it? Do you want to tell us what it was?
Meconium drug screen.
Yeah.
Yeah, we looked at every birth that had prenatal care and looked at how often MEC screens and urine drug screens were done by race and found disparities in the ordering rates.
You want to know where most good ideas come from? I was at a football game, sat near Chris Frank. Michigan was up by a lot, so we were able to chat. And he said, you know what, I think, you know, when women deliver, I think someone kind of looks at women and says, let's order a drug screen for this baby and not that one. And he said, I kind of feel like it might be race-based and not super hard of a data pull, right? And a definite difference. And so now it's about like looking at other institutions and could you replicate this? What can we do to make, you know, screening standard? I mean, this is true too of screening pregnant mothers, you know, the big syphilis issue now with newborns and. So a lot of OPs, I think, are still like, oh, I'll screen this one, not this one. So really doable, really impactful project. And then this is Elliot Tapper. I'm sure Jeremy, you know, but he just said, I have IRB approval to email patients for recruitment, but it's gonna take, you know, my student forever to get the emails out of, and he just uploaded a list of his medical record numbers, downloaded their emails, and he was off and going in like 5 minutes. So other just uses of the tool. And then how many of you guys have used eMERS? It takes some practice, but it's pretty powerful. And David Hanauer, bless you, continues to invest in it and make it more robust. It's now in about 8 different health systems. So it's pretty powerful. This was an amazing study. How many patients with this rare leiomyosarcoma at Michigan Medicine? If you look just in Data Direct, it's at 101 patients. So then she looked in eMERS and said 311. So it's like, wow, that was way off. But by the time you could look in eMERS and put in negation, it was the truest answer was probably 128. But she could redo her eMERS search to say, you know, look for rule out cutaneous leiomyoma, look for, you know, no evidence of things like that. And she got to the truer case. So again, with a little playing around with it, you can quickly get to some of the truer numbers there. We do so many consultations. I think this is probably the most important thing we do aside from data. I mean, just even brainstorming with you, what are you trying to study? Where might that data be found? How can we get it to you? Things like that. So just, I encourage you to do that.
Can I ask you?
Yeah, please.
So we've been doing kind of scheduled data pulls for quite some time.
Yeah.
And Richard recently got clarity access.
Yes, he told me.
He's
Very excited
about it. And so, you know, I think one of the things that I've been wondering is obviously for the scheduled pulls, you know, we still go through you all, but like, is there any uniform way that like he should interact as far as like making adjustments if he wants to make adjustments and things like that to the or like does he write his own code and then hand it to you guys? You guys still like do it yourselves?
He can, we have a great partnership with a group in HITS who does the scheduling. And so Joe Lipa, it's one guy. And so you could just say to him, can you, line 3 of the code, can you change this? And then just schedule that. So I can connect Richard and Joe because then he can go probably.
We're for our multi-center registry, we're potentially making some changes and I just want to make sure that everything's.
Yeah. Okay, great. I'm glad you asked that. Okay, great.
I have a theoretical question about your consultations.
Yes.
So I've worked with you guys and I know you are superb at making sure that compliance and IRB is in line. How do you envision your role in thinking about the legitimacy of methods or research questions?
Oh, do we govern science?
Yeah, do you guys think, I mean, I don't think there's a right or wrong answer to that. I was just curious how you all think about that.
You know, we're just lucky. I think we're just lucky because I have 2 to 3 people on my team. Robinson is one who are PhD trained scientists who didn't want to try and keep a lab going and fight for funding. They switched into data and research. So they are incredibly savvy at saying, we're not going to be able to answer that when you're, but I don't think it's an expectation, but we just try and educate enough on the data that hopefully it informs science. Do you guys know Brahmar Mukherjee from School of Public Health? So she's been named something fancy of research data strategy across the institution. And so we talk about the integrity of the data itself. She talks about the actual analysis, how you're not inadvertently to be knit toward a bias, how you're not, you know. And so she's setting up that hopefully centralized infrastructure to be able to have the methodology, again, point toward better data. First, we try and pull data with integrity and tell you this is lacking, you can or can't probably say this. And then secondly, she's gonna do that. I think that'll help toward the science, but you can pull data and publish on it, and there's no police saying that's crap science. Kevin?
Sorry, I gotta unmute myself. I don't know if I'm jumping ahead here, but I see this little reference here in the lower left to Blue Cross Blue Shield, which is very super interesting. Can you just talk about that a little bit? Because my experience, this goes back a long, long time ago, working directly with Blue Cross. They were very, it was extremely difficult, it's probably the most polite way to say that, to obtain linkable data. So, we had to go through a lot of gymnastics to do that. Can you just say a little bit more about what you have available? Because as you know, Aaron, we do a ton of work with Medicaid. And so often we have that process figured out, how to get approval and permissions to get Medicaid data. But if we have sort of the complementary set of claims for Blue Cross Blue Shield, which is, the largest group of privately insured folks in the state, that's super interesting.
Yeah, and Kevin, I mean, no surprise the inroads to Blue Cross Blue Shield data is really through the CQIs. But a couple of the CQIs have had, lucky, proposing research projects that kind of blur with QI a little bit. A lot of our research projects do. And so they have had success in doing actual research with those as long as it's got through a QI lens kind of.
Okay, good.
And I have Medicaid on here because I've learned a lot from Dr. Reeves about Medicaid. So yeah, I mean, Kevin, if I could connect you with someone, would that be good? And because I think really it's going to come through the CQIs. I don't think Blue Cross is going to hand us a pile of, as you know, IHPI has tried for a long time, but we do better getting like Optum data from United than we do from Blue Cross sometimes. So.
Well, and I mean, the explanation years ago, and there's some truth to this, of course, is that, their charter prohibits certain sharing. And so they're, rightly so, very, very cautious about, making sure they're true to that. So so I don't have a specific ask at this point, Aaron.
Okay.
I'm just curious. So thank you though.
Yeah, absolutely.
I think my specific ask actually is there is not really a pediatric CQI per se, not exactly, right? And so it puts people in this room a little bit of a disadvantage because if they wanted to have, let's say they had a cohort of children with sickle cell anemia, because Sarah's looking at that, and maybe that's not the best example, but because it's mostly Medicaid, but it was just hypothetically, there are some Blue Cross Blue Shield of Michigan children with sickle cell anemia, and you wanted to identify their EHR utilization, their whatever, leverage the kind of richness of that, but then also link to claims so you can understand what's happening at other institutions, right? Or urgent cares, or those types of things. There's no mechanism right now to do that, and that's a pathway that I think is very limiting. And so I'm wondering if there could be some sort of ad hoc BCQI, right? Or something like that, that would be more like, hey, we have a QI-ish kind of type of project. Granted, it's not a CQI, right? For funded by Blue Cross Blue Shield of Michigan, but it's a little bit of a hodgepodge. But kind of that would allow that kind of linkage for specific cohorts.
I talked to Mike Thompson about this recently with Michigan Value Collaborative, and they're willing to pilot QI, like if you can spin it QI or some sort of exploratory thing to think about these things in a broader sense. So it might be feasible to do, like in an ad hoc, like what you're talking about. So that might be the mechanism.
Is he Blue Cross?
He's Michigan Value Collaborative.
Oh, he's MVC. Okay.
Yeah.
And that's all payer?
No, it's all
it's
Blue
just
Cross Blue Shield.
BC only has BCBSM claims.
Okay.
So this is the other thing, right? So there's a pathway to get BCBSM claims through MVC potentially, right?
Okay.
And we have people, Aaron Carlton, who's working with that, with MVC because they had BCBSM claims linked to Experian credit data, for example. So it's actually, they're these things are feasible. But then if you wanted a linkage to Medicaid claims, right, that's through the state, right?
Yes.
Right. And so I just think that the processes, like, to get, if you had the same cohort and you wanted to be all payer, right? You had BCBSM and say Medicaid patients in your same Michigan Medicaid cohort, you'd have to go through two different pathways. And that's fine. I'm just saying, I guess I wish there were a streamlined kind of pathway to make it easier for researchers to do that.
Yeah, I hear you, yeah.
And it was explicit, like how they do that, because I don't think that people were even aware that this is possible. This might even be possible.
Yeah, okay. So even if you had data from the two different sources now, would it still be on the researcher to do the matching of who's who?
Well, no, I mean, I think that there's an honest broker process, right? I mean, you should be able to essentially push forward, right? A bunch of patient IDs, right? With their identifiable information, send it to some honest broker who then does the linkages, sends you back whatever cut of data you need, removes the identifiers, right? The direct identifiers, sends you back some encrypted patient identifiers, right? And so you end up with the data that you want with encrypted patient identifiers, right?
Yeah.
So that's essentially the way MSQC does it with links their data to the prescription drug monitoring program, right? It's through an honest broker. So I don't know, Chad knows, probably of course knows a ton about that, but
yeah,
it should be possible, right?
We do it, yeah. For the PDMP data.
Okay, your office does it.
They send us all the state. This is what the state likes to do. They like to give us all and we'll match to Michigan Medicine. Which we like better than sending out Michigan Medicine patient IDs. When they do that with death data, they do it with the controlled substance data.
Yeah.
And we match, if it's for research, you don't have to match at 99%. If it's for care delivery, you definitely have to. But if I'm 90% sure that this patient is who I think it is for research, as long as you let people know it's 90%, likely. So, I mean, that's definitely possible. And our office would do probabilistic matching, but it'd have to be from two sources. But that's, that's the nature of Pete's Health, right? And how it's paid for.
Similar to what we're doing with the Maker clinical data.
It's been a learning opportunity.
So it just says that MVC has Medicaid and Medicare claims in addition to BCBSM. So I'm not that I wasn't aware of.
But not like not like every claim for everyone.
Right. Right.
So they have Michigan Medicaid and Michigan Medicare.
I don't know anything about the Medicare, but yeah, Michigan Medicaid is linked in there.
So you can go through MVC and you can identify a cohort of patients in Michigan Medicine across payers and match them to both, ask MVC to link them to both Medicaid and BCBSM claims?
That's what's unclear to me because it seems that the actual identifiers that MVC has sits on a separate server and no one's exactly sure who can access that at this point, was my last understanding.
Okay.
Does that make sense? Like the MVC data is actually technically de-identified, although there is identifiable data somewhere else.
Got it, yeah.
Yeah, please. I had a slightly different question. So we have Michigan Medicine EMR data.
Yeah.
Our institution now has these relationships with other institutions that may have Epic-based systems. Do we as Michigan Medicine researchers have an ability to extract their EMR data, like Sparrow or?
Right, not today. You're like a plant in the audience. So that's definitely being worked on. So today, the different network-based research opportunities we have. Soon we're going to be able to get access to Cosmos. Do you guys know what Cosmos is?
I was just looking it up the other day.
Yeah.
If we had joined yet or not, but we haven't.
So any institution with Epic can have their data be added to like the registry of registries, so all Epic users. And so it's fantastic for benchmarking, for hypothesis development, things like that. It's still unclear to me if you would know hey, I'm seeing this pattern and that's Wisconsin, I'm gonna reach out and do a job. I don't know if it's got that matchmaking that PCORI does yet, or if it's anonymized even at the institution level. It's 220 million patients. I mean, it's an enormous set of data. And so we're exploring being part of Cosmos. It would just be another, layer that you could say, is this trend I'm seeing here with the kids, it's going on elsewhere too. It's a great potential.
Is there a timeline for that?
2024, I mean, that couldn't be more vague, but yeah, it's,
All hospital based or all Epic?
no, all
inpatient?
Epic.
Bless you, because that's 2/3 of America.
Yeah.
Okay.
But I bet that's 220
That
million
feels right,
people
though.
over the
Epic's
course of at any
What?
point.
I said Epic
Right,
is
so people could be
decreasing, but it's
duplicated across in multiple, it's not
Yeah.
deduplicated, I would guess it's not
Interesting about
duplicated across the
that.
big.
It's not
Every-
And it's not
No way.
active patients, right.
So that, lots of databases.
There's a lot.
Yeah, it's like anybody that goes to multiple. big networks.
In any given year, maybe 80 billion is my guess.
Correct,
Yeah.
I think that's fair, yeah.
Which is still good, I'm not saying that.
It's yeah, I think this one's gonna be great, but I have a lot of caveats.
You said not active patients are not in there?
Well, so the way, if you went into our system today and looked at Data Direct, it would say there's 5 million unique patients. And that's misleading. It's 5 million unique medical record numbers have been issued. The active patients at Michigan Medicine is under 2 million, and that's patients who have had any contact with the health system in the last 18 months. Some patients, got scheduled for a lab draw, they got a medical record number, they never came. Some have 2 medical record numbers that have been like combined into one. So it's very misleading. So when I say active patients, I usually look, if I really want active patients for recruitment or something, I say like at least 2 visits in the last 18 months.
So all of these would be just like
This was a-
historical accounts.
Yeah, from any Epic user. So you also don't, this is the other caveat, I think. You have to map your Epic instance to a standard, even though we all have Epic, everyone implements it differently. And so there might be differences in mapping. Some might only do living patients. I don't know why you would only do living patients though, especially if you could do retrospective. But there might just be different choices made at different institutes. So it's gonna be hard to know kind of what went into what we're seeing in Cosmos, but hopefully the numbers are so large, you could at least see trends that would help you say, yeah, this is maybe something to go after. The thing about PCORI, the Patient-Centered Outcomes Research Network, is that the point of it is to matchmake. So for something like a rare illness, we have 20 kids here in Michigan with some condition. You could find 4 other health centers with 20 kids. You could, and it would partner you up with PIs at those sites.
We're doing that with CKD right
Oh, you are, okay.
now. It's run out of CHOP, but it's a 17 center
Oh, yeah, okay.
grant and so that's actually one of the reasons I was talking about the completable phenotypes, so I'm gonna do the complete phenotype portion of that.
I mean, I think PEDS is especially conducive to network-based research because there's fewer numbers. And then also for FDA approval stuff, you're not gonna always do a randomized, you're gonna take adult data and say, could we see this might be affected? So to your question about the affiliate sites, so the primary research interest initially was making our trials available to our affiliate sites and making them available locally. And so that's been Julie Lemine's initial focus, is to say, like, you're gonna have a block M on your building that has the promise of like, I'm tapping into Michigan's powerful research community. So the second focus though really is this data and the ability to have a more diverse representative of the state data set. And so I hear zero plans about merging all our data into one big bucket. What I do hear talk of is feeds of data from the affiliate sites on a set of data. Maybe you'd say, I want all diagnosis, meds, labs, encounters, allergies, whatever. And that would come here. And it would be maybe a daily feed or a weekly feed. And it would require some mapping again. But that's what I think we're going to see. The other way you could do it is you could federate, you could send a query out to each instance and bring back the results. You can imagine, I mean, we're always like, oh, we're so short staffed here. these affiliate sites will have like one data guy named Jeremy. Sorry, Jeremy Ethler, not you. But I mean, like, they'll have one data guy who does 50 things. So, you know, I think it would probably be easier to replicate a model like Sachin's MPOG network or something where data are pushed here, and then these sites could have a view into it to do the search if they're interested. We would have a larger file. I don't think we'll merge all of our databases into a single. Do you guys know, for kids you see at Michigan, do they come here for really like critical care issues and then maybe they go back home
Yes,
for primary care sometimes?
Some do, some don't.
Some do, some don't. Okay.
our catchment area is basically the entire state of Michigan.
Yeah. And then part of Ohio and Indiana.
Well, Northern Ohio is going away, so,
They are?
well, because Nationwide bought the Children's Hospital in Toledo, and they also convinced the Medicaid in Ohio to change the reimbursement, so they're not gonna reimburse Michigan care. And so now a bunch of those kids are gonna have to go to Columbus for their specialty care, so
Ohio. What can you do, you guys?
it's pretty ingenious.
Yeah. So anyway, I would love, once we get into actual talks about this, hopefully next year, I would love some people willing to champion and say, if we're gonna get data, we need these 5 things.
Sorry, I'm just thinking like Trinity, like, I mean, cause like IHA is such a dominant kind of, it's a huge primary care network here, right? And I know you can do the care everywhere thing in my chart to kind of look at some of the EHR, but there's not, to my knowledge, some way. And I know that at least my daughter's IHA office just started using Epic for whatever reason. So it just seems like there may be an opportunity if Trinity were willing to somehow merge its data, that we could actually get a better sense of what's happening to kids who are hospitalized at MOD, and then, you know, what ends up happening to them at IHA. I don't know, something like that.
Another like pin I wanted to put in this to make a point, and I know you all have already thought about this, but just so it's on our minds too. Even if we have these data feeds, I don't think it's clear how the legal parameters would work for us to access that in terms of IRBs and DUAs and things like that. That would be a whole other layer of how we think about this.
I mean, once we have it, the DUA has already taken place to get it, but then I think we would apply the same lens to say, you know, is this a waiver of consent, retrospective?
Would U of
secondary
M, I guess,
use?
would U of M be the primary IRB then for Sparrow, my Michigan Metro Health and the Michigan data?
Probably, yes.
Okay.
Like I
Once
said,
the data gets here.
once the data gets here, and even just to move the data, we would probably have a DUA or a BAA. I don't know if we'd be acting as a business associate, but with an umbrella IRB. So the existence of the research data warehouse itself has its own IRB to say for this to exist. And then each project that's going to interrogate the data in there has their own IRB. But yeah.
So then we could almost be like the IRB, central IRB for.
Yes. Yes.
That would be maybe even
Be
nicer
great.
than having all the data.
You know how easy it is.
Well,
Sorry. And you guys know the technicals easy. What you just said, all those letters, those are gonna take.
Sarah, even if the data comes here, I don't know, we wouldn't be the IRB of record for each of those institutions for everything else. It would just be for the data that ends up.
Correct.
Yeah,
But even
that's
that would
right.
be.
Yeah, that would be awesome.
Yeah, no, that'd be. Yeah. Let me just see if there's anything else or if I can show you, I have a bunch of links. I don't know, Sam, if you'll share this. But can I just real quickly, I'm gonna stop sharing and then share data direct. So I can show you where those more granular. Super good. On the Zoom call, can you guys see the data direct? Okay, great. I'm just gonna show where the more granular geolocation data are, Gary's.
Great.
Let's change my level 2 and it's so many caps and kids' names. Jeremy, are you now seeing create a new blank query? Great.
Yes.
thank you. My. Yes. So after I've selected my IRB, to get the granular row level data about geolocation and not just the affluence or disadvantage index, I go to the PHI section. Just for reference, Gary, this last one is the recruitment, where I define my eligibility.
Great.
And then I set a schedule of how frequently I'm on it. This one is that extra layer of IRB that says, yes, you can have their phone and their email to contact them. This is just PHI that's mainly dates, it's mainly a limited data set. And so we would create our population here. I'll just make it up a big group. And I'm gonna put it 0 to 20. And that, and who has a diagnosis of interest? That. And then down here, under demographic, I'm under output view selection, under demographic. Anything that starts with GIS refers to the geolocation data. And let me just scroll and show you how many views there are. So it takes some exploring. Here's by grocery, proximity to liquor and tobacco stores, parks, family history, urban, rural. I mean, there's an unbelievable number of, buried in here is ancestry, if we have it, if a patient's in. Patient race, this has some of the new more granular categories, but this is kind of I'm gonna click on this, and then we would need to, choose whichever one of these. Proportion of persons 5 and older who do not speak English well in the house. I mean, here's how many, age groups live in what house, single parent, female headed household. And here's the way, oh, darn, that doesn't have the snapshot of the data. Let me see if I can get one with, just to show you guys what the data will look like. This little, yeah, okay. For each of these types of data elements here, each one of those is a column. And so what you'll get is percentages. And so it'll say something, I picked a bad view. Broadband access. Here's ISR. So these might be all counts, but basically it'll say things like 40 or 35. That means that's a percentage of homes on that block that have.
I don't think we're seeing.
Oh, I'm so sorry. I'm really good at Zoom. It's only been 4 years on Zoom. So when you get the data, this is when it'd be great to link up with someone in my office and someone in ISR to say, what do I make of these numbers? Most of the time it's a percentage. And so if it's homes with, English is not the first language, you would see for this patient, that column would say 30. That means 30% of the homes on this block speak a language other than English at home. So usually, but each one of these will have a link in here to the NANDA data. See where it is. We just clicked it out here. The webpage, I still don't think that goes very deep in telling you what to make of those numbers. So I think sometimes it helps to have a quick call, and Philippa will say, well, these were collected in this year. So you could, but most of them don't change, year to year. So you probably could say this or that, but it's a proportion. Each value is a proportion. portion in these columns.
Right, thanks for showing.
Yeah,
Sorry, and the granularity is block, not census tract.
census block ID,
Okay.
yeah. Is that smaller than a census tract? Yes, the block is the smaller.
But it's not like a city block necessarily.
Yeah, right, but it's a census.
It's a census block.
Right. Jenny Lee?
Yeah, I was just wondering if it was, if it'd be possible to show where the patients in care survey is on Data Direct while you had it
Oh,
open.
yes, thank you.
Thank you.
Great, okay, back in output view selection. Toward the bottom, there's a group called survey. And questionnaires, let me see if it's under here, nope. MGI. Oh, shoot, I don't see it. You know what, Jenny, thank you for bringing that up. Let me see where we have it. It's in the database, but I'm not seeing it in the in Data Direct. So I don't, maybe it hasn't been exposed. I'm so glad you mentioned that. Let me find that one.
Is there any kind of like code repository or GitHub for folks that are using Data Direct?
Yeah, that's a great question. Let me show you. Don't let my ability to work these slides scare you off from. In the slides I'll send out, this documentation site is a data dictionary. It's got, and we have a librarian who's constantly updating it, but you could search for a term or a view, or it's fairly user friendly, but if you can't find something, let us know. Yeah. I took way too much time.
This was great. Thank
I
you so
love
much.
working with this group, obviously.
Thank you so much for coming.
Yeah, so send me an email with any follow-up questions, or if you want to set up a meeting, anything.
This was really helpful. Thank you.
Great, thanks so much, Harry.
Thanks, Aaron.
Thanks, Kevin. Good seeing you.
See ya.